to all the experts who have joined and given us this opportunity, provided their valuable time over a weekend for this scientific discussion, for knowing more on RAS blockers in improving the cardiovascular outcomes. The panel for today's discussion comprise of our moderator, Professor Soumitra Ray sir, who requires no introduction. He has been a senior faculty. We have seen him in various national and international forums, and he's been mentor to many students in the country. He's a consultant cardiologist, a fellow of CSI. He is consultant at Shri Aurobindo Seva Kendra and Manipal Hospital at Kolkata. I welcome you, sir, and look forward for your valuable guidance today.
Thank you, Dr. Ajay.
The panel comprise of experts like Dr. Mrutyunjaya Behera sir, who is ex-professor and HOD, SCP Medical College, senior consultant and interventional cardiologist, Kalinga Hospital and Ashwini Hospital at Cuttack. Thanks for joining, sir. Dr. Manoj Gupta sir, who is a consultant cardiologist, HOD and Director of Cardiology at Trimurti Hospital at Varanasi. Dr. Manoj Kumar Sharma sir, who is an interventional cardiologist at Metro Heart Institute, Noida. And Dr. Bappaditya Kumar sir, who is a DM cardiologist, consultant interventional cardiologist at Nightingale Hospital at Kolkata. I welcome all the experts today for this fruitful discussion what we are going to have in the next 50 minutes. The agenda of today's discussion would revolve around the role of RAS blockers in post-MI. So before I hand over the session to Professor Soumitra Ray sir, I request my audience to please post their questions, their queries in the chat box so that our Enlight panel can take them whenever we get the time for the discussion. So without further ado, may I request our moderator, Soumitra Ray sir. Over to you, sir.
Thank you. Good evening. Welcome all. And I'm very surprised, pleasantly surprised to see the fantastic mix of my faculty today over here, both geographically and age-wise, from the very senior consultant like Professor Mrityunjay Behera to the youngster like Bappaditya Kumar and two Manoj in between. So it has to be a fantastic discussion of past and present and future, all on the same platform. And I also must say, and that I also must congratulate Dr. Anup Hajare to pick up this subject and to make a slide set, which I found is very interesting. I think you will agree at the end of the discussion that it's a very interesting slide set. And some of these we have forgotten. It is too old, but how relevant these are in today's context, I'm surprised to discover myself that why didn't we discuss it before? Let's go through the things a bit quickly. I'll go on my part so that we have got much more time to get your verdict and your opinion along with the questions and clarification from the delegates. So here is RAS blocker in acute MI from safe to paradise. So, and you must realize and accept that this is still a very controversial area. Whether ARB causes more heart attack than ACE inhibitor, whether ARNI is equivalent or better or worse than ACE inhibitor in a post-MI setting. In certain other settings, the answers we have got more or less clear, but this setting is still a bit enigmatic. We'll discuss those. And these are the areas which we'll discuss: the ACE inhibitor, ARB, ARNI, and the guidelines, all in the perspective of post-MI. So first come first is the ACE inhibitor. There are two categories of trial with ACE inhibitor after an MI. Of course, there are a lot of other trials in heart failure, in hypertension, and in high-risk population. But this is only for post-MI situation. Some are long-term trial, which is selective, high-risk long-term. Some are short-term, broad-term trial. And I will go through them, one or two slides with each trial so that we can have a recapitulation. These are so old that we read it in our MBBS or MD days or DM days and then perhaps have forgotten. So SAVE in 92 and all this SAVE, IR and TRACE trial, they are around 2,000 patients with captopril, ramipril, and trandolapril. So 3 different type of ACE inhibitor. And when were they started? Captopril was started between 3 days to 16 days after an MI, and it showed to reduce mortality and morbidity. Ramipril started between 3 days and 9 days after an MI and reduced mortality. And trandolapril started between 3 days and 7 days and reduced a composite endpoint. So you see that a very interesting common feature is that all of them were started after 3 days. Once the patients are hemodynamically bit stable, and once the most serious patients have died out, about 5–10% patients die after heart attack, and those were excluded automatically because of the inclusion criteria. And you see the standard doses were given, like captopril, the highest dose of the target, with ramipril, also the target dose, but very interesting, it was 5 BD, not 10 OD. So that is very interesting to note also. So whatever we conclude, it was on 5 milligram twice daily dosing. That we sometimes tend to forget. Give 10 milligram OD. Trandolapril we don't use so much. Selection criteria I told. And ejection fraction, say if it was below 40%, had to be documented. In IR study, ramipril with heart failure, clinical or radiographic, there was no ejection fraction business over here. And in TRACE trial, again, there was echocardiography, and there was ejection was 35. So we can say either clinical or echocardiographic evidence of heart failure was there. Age was all adult patient, and follow-up was really a long-term follow-up, 42 months, 15 months, 24, so at least 1 year up to 4 years. And what did we find? In the SAVE trial, as you say, you see the curve separated about a year after, not immediately. So after 1 year, you get the benefit, 20% reduction in mortality and 25% reduction of a second heart attack. And cavity dilatation, so remodeling was checked, and these benefits occurred equally who are thrombolized with beta blocker, you know, the TIMI2 trial, or who didn't get the streptokinase and atenolol. So standard treatment in 90s was streptokinase and atenolol. So even when patient did not get it, they got the equal benefit. So that was an interesting observation. So irrespective of revascularization status, by the contemporary technique, captopril worked. IR trial with ramipril, again, acute MI, as we said, 15 months follow-up. And here we get around 30% mortality reduction and around 20% of heart attack and stroke reduction at 6 months. So it was a very interesting study and gave you a good follow-up. And it was extended. This study was extended with a few patients, about 1/3 of patients, 600 patients out of 1,800. And they were followed up for about 4 years. And what was found, that beneficial effect of ramipril, which started early after MI with heart failure, are sustained over next 3 to 4 years, despite you stop the medicine at 1 year. This is very interesting. Ramipril was stopped after 1 year, but still after 3 to 4 years, you are getting a mortality reduction of 36% and absolute risk reduction about 10%. Which is very good. Absolute risk reduction 10% is very good. So even if you stop the ramipril, so the question comes, what is it is an early effect and there is no point continuing it, which is coming with beta blocker. After 1 or 2 years of MI, there is no point continuing it. I mean, no extra benefit. So maybe that was true with ramipril. And that trandolapril with TRACE trial also, as we mentioned, that 25% reduction in mortality, 15% with MI, 20% of sudden cardiac death. This is another interesting finding with sudden cardiac death included. So these are the acute MI and long term. Short term, when you get much more patient. Instead of around 2,000, here the average number is 20,000, 20 to 50 to 60,000 even patients, but they're short term. Captopril in reducing 5-week mortality in ISIS-4, but it was maintained long term, just like IR study. GC3 lisinopril started within 24 hours. Now that is interesting. Now not 3 days, but within 1 day. So we are getting more adventurous. And that also showed mortality and ventricular dysfunction was significantly reduced. 15,000 patients with captopril, again, anterior wall infarct and lower mortality, about p-value 0.02. So again, 2 studies with captopril, 1 with lisinopril. And these are bigger study, but short-term study. But again, in short term, they showed benefit. And even with it starting within 24 hours, they showed benefit. Just quickly, GC3, about 20,000 patients, lisinopril, nitrate, or a combination or placebo. And only 6 weeks follow-up. So lisinopril started within 24 hours of a heart attack, produced significant reduction of mortality, and a combined outcome of mortality and ventricular dysfunction. And combined administration of lisinopril and GTN also produced significant reduction in overall mortality and combined endpoint. So it's good whether you add GTN or not. ISIS-4, a huge study, 2,000 patients, 58,000 patients, huge study. Again, within 24 hours, within onset of symptom of suspected MI, and captopril showed within 5 weeks. So you don't have to wait for 1 year, like which was shown in the earlier trial, because you are perhaps starting early, so you're getting an early benefit. And CCS trial, 15,000 patients, this is starting within 36 hours, not 3 days, not 72 hours, but within 36 hours. And again, you get a benefit. This was limited to anterior wall infarct. So I go to Sir, Professor Behra. Will you start an ACE inhibitor in all the patients with ACS, whether revascularization procedure was performed or not, expecting a mortality benefit? In today's world, sir, we have come along from streptokinase and atenolol to primary angioplasty. So do you think these results still hold good? Sir, you unmute yourself.
Okay. Before I start, I want to say something. I agree on one point that I am one of the senior most faculty in this zone. And why I am saying so, because when the remipil results came out, IR study results came out in 1993, I was virtually the brand ambassador of remipil at that time. Because in all the meetings in this area, I was the only assistant professor available in the SM Medical College. So I used to give talk on anatomy. So this starts from...
It's our extreme privilege, sir, to get you on board today.
Thank you.
We really congratulate you, sir.
So I have always a liking and some sort of soft corner for ACE inhibitor, especially remipil, in view of the IR study. Then the question is whether this can be given to all ACS patients. The ball started rolling, from HOPE study, which involved more than 9,000 patients. All these patients were high-risk patients. 2 subgroup of patients, those who had SCVD or peripheral vascular disease, coronary disease, or stroke, and the second group have diabetes and risk factors. So it showed a considerable benefit as far as mortality and morbidity is concerned. Moreover, it showed that you can reduce the incidence of diabetes in this set of patients. So this drug theoretically can be given to all patients of ASCVD and high-risk patients. The question is, can you give this drug to all patients of ACS? Yes, the ACS include both NST-MI as well as ST-elevated MI. ARX study all showed that it gives us a considerable benefit. In fact, ARX showed that if you you are giving this drug, you can prolong the life of 114 more patients in comparison to the placebo. So the message is very clear. It can be given to all patients, but there are some problem with NSTMI patients who had heart failure. This had some problem in the sense the result was not as good as what was seen with ST elevated MI. So to answer your question, this can be given to all patients, but then you will have to use your judgment. And if a patient has a heart failure, there is no reason that you cannot give this drug to patient. All this controversy would not have come. Only it came because of the Paradise MI trial. Paradise MI trial showed that this did not show benefit with the ARNI vis-a-vis Remicade. In fact, the tendency of a benefit was there with ARNI, but later on post-hoc analysis showed that if you prolong the drug for a long time with ARNI, maybe you will get better results. But for what we have seen in the ESC or SCCHA guidelines, the guidelines always say that you will have to give a ACE inhibitor in patients who have a heart failure. But then nowadays the ESC guideline has changed, so you can change over to ARNI if you are giving ACE inhibitor to these patients.
Great, sir. It's nice to see from a person from the horse's mouth who has seen the ramipril bond and now ramipril in such a huge tree. So, and it's very encouraging to see that SARS confidence on ramipril hasn't been disturbed over last 30 years. So over last 30, 35 years, his confidence grew from strength to strength rather than there was any kind of doubt. Dr. Hajara, I have got a clarification here. This question you have given a very broad base. Do you mean that all patients with ACS with heart failure or just ACS with or without heart failure?
So
what is in your mind?
ACS with or without heart failure, sir?
So it is an all-comer ACS,
Yeah.
or non-STEMI, anterior or inferior wall, with or without heart failure, with or without revascularization. So that is a very optimistic statement. Like nowadays, still we have got a kind of guideline that class 1A is when it is an anterior infarct and when there is some clinical or echocardiographic evidence of left ventricular dysfunction. Whether it is an uncomplicated inferior wall MI with ejection fraction 65%, whether ACE inhibitor, early ACE inhibitor helps or not, some of us have got still some doubt about it, whether it should be to all comer. Secondly, the question of revascularization is very important because no proper long-term study has been done after primary angioplasty with the role of ACE inhibitor. We really do not know whether this very early revascularization leaves any scope for the ACE inhibitor to make some extra improvement in terms of left ventricular ejection. So there are certain caveats, but I would rather say that all high-risk patient of ACE inhibitor, the indication increases if it is anterior MI, if the patient is diabetic, if there is a hint of left ventricular dysfunction, then of course the becomes almost mandatory or obligatory to give ACE inhibitor. In others, you choose, because in all ischemic heart disease, RAS blockade is the one of the 3 or 4 event reducing or prognostically beneficial medicine. So in that sense, you can always give ACE inhibitor in all these. Now coming to ARB, we have got some limited trial with ARB, optimal or valiant with losartan and valsartan, about 5 to 15,000 patient. Losartan, but very interestingly, they were given compared to another ACE inhibitor, not compared to placebo. Because when they came, then ACE inhibitor was already established as a treatment, and you really cannot have a placebo arm. So if you see, so the job becomes difficult for ARB. They had to show superiority rather than to placebo, but rather than to a very strong opponent. So losartan versus captopril. And here you also see that losartan was given once daily, and whereas captopril is given 3 times daily, which is perhaps in your mind a bit unfair, because losartan should be given for effect twice daily, isn't it? And where you are giving captopril in the full proper dose. Valsartan is again given, and I'll go to the result. The optimal showed that even with that, losartan was doing well. Non-significant difference in total mortality in favor of captopril. Captopril was better than losartan, even with a handicapped dose of losartan, but still it's not significantly better, even after 3 years. ACE inhibitor should remain the first choice treatment in patient after complicated acute MI. So losartan cannot be generally recommended, particularly at that dose. Then came the next year, 2003, the Valiant trial. Mortality from any cause and cause-specific mortality was similar in the 3 treatment group: captopril, valsartan, and a combination. But the rate of secondary endpoint of death from cardiovascular cause, MI, or hospitalization of heart failure was also similar in the 3 groups. But the 3rd group was abandoned because of high side effects of postural hypotension and hyperkalemia. So between captopril and valsartan, again, there are not much of difference. And that's why we say that if you choose ARB post-MI, you choose valsartan, which has got the maximum evidence compared to telmisartan, olmesartan, or even losartan. So I go to Dr. Manoj Sharma with these 2 things in mind. Will you switch the patient to an ACE inhibitor if the patient came to the hospital with an MI and was already on ARB for his blood pressure? Dr. Sharma, please.
Thank you, sir. Thank you for sharing the stage with me. And I am very grateful for this.
So could you be a bit louder, slightly louder?
Okay, sir. Thank you so much, sir.
Yeah, thank you.
So the question is, the patient with ACE inhibitor who are have a post-MI period and already taking ARB for hypertension, can we switch the patient to ACE inhibitor or not? So according to sir, as already we have seen in the previous slides and the various comparisons, there is no significant difference seen in the studies that ARB is giving a upper edge. As sir already said, captopril is given in the full dose, and losartan was not given in full dose. In spite of that also having a no significant difference. But still, from the previous studies, they all are showing that ACE inhibitor have a better mortality benefits and morbidity benefits. So I don't think so. We need to change the drug, and usually we don't do that. And if patient is on ARB, or if we give him a full dose, or patient is not having any issues like with ACE inhibitor like cough and other things, then we can continue with that also.
So, sir, I have got a.
Can I add something?
Yeah,
yes,
I'll actually come to you, Dr. Bera. I'll come to you because I need your opinion. But Dr. Sharma, are you a taker or believer of ARB paradox of increasing MI? Do you believe in that? I mean, there are a lot of conflicting evidence.
Yes, sir. That is actually a debatable thing, basically. If patient is having no issues with other things, I think we can continue. Or if patient is having some, other things like increase in, allergies to that thing, ACE inhibitors and other things, bradycardia, increase in bradykinin that results in all these things, and or cough and other things, then we can, continue with that.
So, Dr. Bera, please. Thank you. Dr. Bera, your opinion, please, on this particular issue.
The question is whether you can switch over from ARBs to ACE inhibitor.
Yes, sir.
I think the switching issue is settled now. The data on ACE inhibitor is robust, very robust, like IR study or for that matter HOPE study. This ACE inhibitor data is robust. The type of mortality benefit, the type of benefit in the secondary endpoints of all these, in the trials, so that there is a remarkable difference between placebo and so that is the reason the ESC, change rule that you must give S inhibitor. That was a class 1A agent at that time. And then in this era of ARNI, if there is indication, you must switch over to the ARNI because it gives more mortality benefit.
Yes,
So
sir.
there is no reason if a patient is a post-MI patient, you should stick to losartan or those statins, olmesartan. There's no reason. There are no trials involving olmesartan in patients with post-MI. So if you want to get it, you want to give a state-of-art drug or GDMT drug, it is S inhibitor, especially either Remipil or Perindopril. There is a lot of studies on Perindopril also. So you can give one of them. Not only these drugs are load reducers, help in heart failure, but they address many other issues. Which most important issue is the endothelial dysfunction. No other drug has that type of benefit as comparison to the S inhibitors. So if you have a chance, if I am given a chance, I will switch over to S inhibitor. But the question arises now in the era
S inhibitor or ARNI?
ARNI. That will come
ARNI.
later. That will come later.
That was the thing, sir.
ARNI. In this era of ARNI, on the third day, can I put a patient of acute interval MI with LVF, he is in pulmonary edema, and gradually settle it down, put him on ARNI or not? That issue has to
We
be
come to that, sir. We have got a separate section for that.
Right.
So, Dr. Sharma, I think there are certain facts which are very arguable. I am subject to argument. First is a patient on ARB, if comes with a heart attack, in your back of your mind, he might think that is ARB one of the contributor to the heart attack because of the old trials which showed that ARB might increase. So why should I continue it? Why don't I change it unless there is a pressing need? That is number one. Number two, in 99 out of 100 cases in India, the ARB the patient is on is either telmisartan or olmesartan. It's not valsartan or losartan. And there is no data at all with telmisartan or olmesartan that it can be given after MI or in heart failure patient. So you have to switch to valsartan or losartan anyway. So why don't you switch to S inhibitor rather than to valsartan or losartan?
No, sir. Basically, we change it, but we change you to ARNI most commonly.
Yeah, that's a different issue. I'm not clubbing ARNI with ARB. That's a totally separate issue. So I think we all agree that if a patient comes on ARB with a heart attack, it is an opportunity to shift him to at least to S inhibitor. If not ARNI, that we'll discuss later on. No point continuing with the simple ARB of telmisartan or olmesartan. That we agree to that. Okay. So next we come to ARNI. What is the hot spot now? So I have got some very good data over here. We know the Paradise MI, which is again a bit very controversial trial, but done by a person like Mark Pfeiffer, and all the big names are there in the trial. So ARB following MI, primary results of Paradise MI. Let's see it a bit in a scanning way. AMI within 12 hours up to 7 days. Ejection below 40 and or clinical heart failure. So either is so there are patients whose ejection we did not know, but they had got pulmonary edema. Plus one risk factor. So there has to be, these are very strict inclusion criteria. Either they are elderly people or CKD people or diabetic people or old MI or atrial fibrillation or ejection below 30 itself, which will qualify, or KILIP class 3, that will also qualify, or STEMI, who was not reperfused. So these patients are very likely to go into overt left ventricular failure with reduced ejection fraction. So those patients who are chosen, who are likely to proceed to low EF in long term. Major exclusion was already known heart failure patient, unstable patient, or advanced class stage 3 or more EGFR. There's no run-in. You start in straight with sacubitril valsartan with the target of the highest dose, or ramipril target is again 5 milligram BD. So remember, all the trials of ramipril, starting from IR to Paradise, was 5 milligram BD. not 5 milligram OD or 10 milligram OD. So if we really use ramipril in this purpose, we have to use 5 BD. That is a learning point for me also. I also missed the point. I used to give 10 milligram OD. So it has to be 5 milligram BD. And the large number of patients, almost 3,000 on either side. And primary endpoint was cardiovascular death, HHF, or outpatient development of heart failure. A secondary endpoint was cardiovascular death or fast heart failure, hospitalization. A lot of people, India contributed 330 people, and compared to United States, which contributed 455. So India is one of the highest countries I can see in terms of contribution. You see, if you go through this, 330 is crossed only by Netherlands, 342. I can't see anything else which crossed 330. Fantastic. So 330 is the second highest number of patients which India contributed to this trial. Excellent. So what I can say straight away, that all the results are applicable to Indian patients in our country, in India. And they were about 3/4 are STEMI, 1/4 was non-STEMI. So here, Professor Behra's original, the question came, all SCS. I mean, both STEMI and non-STEMI came. So 1/4 of the patients were non-STEMI. Reperfusion was done almost in 90% patient in today's world, of course. Not necessarily PCI, not necessarily primary PCI. Those were not given. All kind of PCI or lighting followed by PCI, pharmacoinvasive. Anterior 2/3, inferior 20%. Again, it answered my question, not just anterior MI, but even inferior MI, 20% of inferior MI. Time of randomization is usually on the day 2. Ejection is approximately 35%. Clip class, higher class in more than about 3/5 of the patient, 60% of the patient. They are on dual antiplatelet, a very good number on beta blocker. Half of them were on aldosterone antagonist. Statin was almost universal. And ACE inhibitor or ARB was on 80%. So that is the profile the patients were on. Now, primary outcome showed this composite endpoint in favor of sacubitril, but no significant difference. 10% benefit, which started early after month 1 or 2, but it never increased after the first month or so. It remained static over next 3 years, and the curves really did not separate. Almost a parallel curve went on for 3 years monotonously, and ultimately it remained at 10% benefit, but which did not achieve the statistical significance. Though there are a lot of events and lot of patient number, but still they could not achieve the primary benefit. Now, ethics committee adjudicated outcome versus the clinician adjudicated outcome. In the ethics committee adjudicated outcome, there was no benefit of sacubitril valsartan in primary outcome, in cardiovascular death, in heart failure hospitalization, or outpatient hospital hospitalization. In no way there was any benefit, though there is a little trend in the outpatient heart failure hospitalization. But when you come to investigator-reported primary outcome, then the primary outcome became significant. That is interesting, in favor of sacubitril valsartan. And outpatient heart failure really becomes significant, 5.7% versus 3.9%. So I am not very sure, I'm not a very good statistician. How do you interpret these ethical committee permitted, ethics committee permitted analysis versus investigator reported analysis? So maybe investigator reported analysis are showing more heart failure when the ethics committee said, no, this is not an heart failure, or the other way around. Something happened between the two to draw that. You can understand this primary outcome difference is influenced by the outpatient heart failure difference. That's why it became significant, because CV death and total heart failure hospitalization remain same. That means not significant. What actually drew this in favor of ARNI was the outpatient heart failure, which actually influenced the primary outcome as a part of the composite outcome. And if you see the secondary outcome, again, the cardiovascular death or heart failure, if you combine them, no. Outpatient and heart failure, so A plus B, B plus C, A plus C. If you see in 3 ways, again, there is no difference, excepting the 4th one, CV death and total hospitalization for heart failure, MI and stroke, just barely 0.04, hardly anything. So overall, but where is the difference? Adverse event, there is a difference. And again, it is balanced. Hypotension is significantly more with ARNI and cough is significantly more with ramipril. Makes sense. That means it was a good study. It was an ethical study, not anything, nothing done underhand, because it showed the real world picture. ARNI produced much more hypotension, almost in 30% of cases. And cough is more with ramipril. Now you balance what you want. So if you see here, cough, even discontinuation due to cough was twice with ramipril, 2 times more, and that was significant. Whereas hypotension was 2 times more, again exactly balanced, 2 times this side and 2 times that side. So again, this is very interesting that you discontinue 1.2% of ramipril and 1.3% of sacubitril valsartan on either side. All death, it is not different at all, not at all. 12% difference in favor of sacubitril, but really didn't change the all-cause mortality. So in summary, this is a very interesting trial. Sacubitril valsartan did not result in a significantly lower rate of death, heart failure hospitalization, or outpatient heart failure requiring treatment. Pre-specified observation of reduction in both the investigator report of the primary composite as well as the total adjudicated events report incremental clinical benefit of sacubitril valsartan, but didn't increase with time. That is very interesting. The safety and tolerability of sacubitril valsartan in this population was comparable to that of ACE inhibitor. One on this side, one on that side. Hypotension versus bad cough. These were the headlines came up in 2021. Paradise MI, Sac-Val can't beat ramipril. Paradise MI makes me question the benefit of Sac-Val and this kind of thing. So there was resurgence of ACE inhibitor, which was going out of sight because of the huge advent of ARNI in different segments of cardiovascular disease, particularly all kinds of heart failure. Sac-Val did not outperform ACE inhibitor after MI and so on. So I go to Dr. Manoj Gupta with this very interesting data in your armamentarium. Sir, why do you think ARNI could not show statistically significant reduction in primary endpoint in Paradise MI trial? Very interesting question, sir. Thought-provoking.
Yeah. Good evening, sir. So I think this Paradise MI is the only evidence which we have in patients of MI where we have compared ramipril with sacubitril valsartan. And I was also surprised because I was actually expecting the result to be same like Paragon or this Paradigm heart failure trial. But in MI patients, the scenario is actually totally different. This is a different subsets of patients. MI patients are not the same patients as we have seen in trial of Paradigm heart failure. They were patients of chronic heart failure patients. They were symptomatic patients with class 2, class 3 patients. So what I can expect if ARNI is definitely superior to ACE inhibitor if you take that same heart failure patient which were studied in this Paradigm heart failure. But in MI patients, you see there are many pathophysiological changes like there is different neurohormonal status of the patients compared to the chronic heart failure patients. There we have the thrombotic milieu is there, and there is necrosis of myocardium. There is infarct expansions, remodeling. All these kinds of things are there. So these are different. So we cannot expect the same results what we have seen in this paradigm heart failure. I think it will take some times, like 2 or 3 weeks, maybe 4 or 5 weeks, where this ARNI will show superior or results to ACE inhibitor. And I think till the things are very clear, we should give some advantage to ARNI in post-MI patient, especially those who have large infarct patient in heart failure with poor ejection fraction, because this drug is definitely showing some positive benefit in terms of late reduction in hospitalization for heart failure. So in selected patient, this all depends on the clinicians, whether they want to start patient on ARNI, especially those large anterior wall MI with heart failure, so that we can achieve maximum benefit.
Absolutely. There are lots of controversies came, various authorities gave different opinions. The one thing I just, so that I brought this slide back, you see, these are very high risk patients. As we have already mentioned, inclusion criteria was very stringent, and it was they are very high risk patients. But still, you see the 3-year mortality is so low.
Yeah, yeah.
The overall mortality is so low, 0.1%. So that means with today's world, with all the primary angioplasty, with ticagrelor, with highest dose of statin, and with other lifestyle management, we have got left very little area to improve by other medicine. That is number one. So we are doing almost a very good thing. I'm coming to you, Dr. Behra. We are doing a very good thing to our patients with the modern management, so that the supportive treatment, these are supportive treatment. These statin, these ACE inhibitor, beta blockers, these are all supportive treatment. So the primary treatment has improved so much that the supportive treatment's role is becoming a bit less. Even without supporting treatment, the mortality is very low. That is number one. Number two is that if you see the criteria, echo ejection below 45 was not an essential criteria. Even with a failure, and many patients with acute MI have got LVF and pulmonary edema with a good ejection fraction because of heart stiffening, diastolic dysfunction. And you did not show any good benefit, convincing benefit of ARNI in those patients anyway. So they might collude and influence the outcome of total outcome of these patients, because not all of them are HFrEF patients. Thirdly, many of these patients with good revascularization, their stunning and hibernation goes off, and they don't land up with actually low ejection fraction after 3 months. Their ejection fraction may be 45% or 40% on day 1, which becomes 60% even without any of this medicine after 3 months, just because of revascularization. So there, anyway, the role of ARNI goes off. So all these things, I think, have made up the thing. And I'm sure that if ARNI could have a chance to be tested against placebo, like what Ramipril had the chance to be tested against placebo, if ARNI could have chance to be tested against placebo, it could have shown a very good benefit and significant benefit. Might be. So that is open to question. Dr. Behra, you are going to say something.
Yes. What I want to say that Paradise MI was not a negative trial.
Yeah, absolutely.
That was still a trend. 10% is not a small difference. It did not meet the statistical significance, but then the trend was there that they did well with ARNI. And then why it did not show statistical significance is for the fact that majority of patients were very sick. You know, in this group of patients, more than 20% have a previous MI. Over and above had a fresh MI. And hypotension was more in the ARNI group. So all these things led to the fact that they had more mortality or more sickness. The events were more in this group, but still then it was better in comparison to the Remicade. Second thing is that this thing was discussed with Dr. Pieper, who was the prime investigator in Paradise MI, and then was also discussed with Dr. Murray and Milton Parker, you know them. So all of them agreed that if the trial would continue, simple. If a patient has interval MI, his ejection fraction, he is sick now, his ejection fraction is 30%. After 1 month, he comes to your clinic walking. He still has a ejection fraction of 30 to 35%. He is on S inhibitor. He is very stable with drugs, S inhibitor. Should you continue S inhibitor or change over to ARNI? I will change over to ARNI at that stage because ARNI has shown a long-term mortality benefit which is much more superior to S inhibitors.
Exactly, sir. There is a very interesting discussion over here.
May I add something?
Yes, please. Yes, Bappa.
Sir, as I was going through the Paradise MI trial, I found that to be statistically significant, 15% relative risk reduction was required. But the trial achieved 10% relative risk reduction. But the numbers was, though not statistically significant, but the numbers were in favor of the ARNI group. Another thing was that the patients were picked up too early in the heart failure journey, as early as first day of the heart failure journey, say. So the patients were picked up too early and were followed up for just 23 months. So further follow-up was required perhaps to get a better idea about the ARNI effect.
That's what Dr. Pini said. Yeah.
Another thing you already discussed regarding the primary PCI revascularization and antiplatelets. So these are the main factors that play in the AMI setting.
One more interesting situation arises. I'm in continuation with Dr. Behera. After 1 month or 6 weeks, when the patient comes with still low ejection fraction, now the patient you can stamp is as a chronic HEPREP patient, and who is an ideal candidate for ARNI, and all S inhibitors should be shifted to ARNI at class 1A recommendation after 6 weeks to 3 months if they still in HEPREF. So there is no question about that. That question comes the other way around. Now the patient comes with 60% ejection. What are you supposed to do? The patient is on ARNI. Are you going to keep ARNI for the rest of your life? Now here comes a very critical hair-splitting analysis. You think very carefully, sir. If this patient was supposed to have his own recovery by hibernation and stunning going off without any medicine, by his own autonomous recovery, then he is not supposed to get any further drug unnecessarily for the rest 30, 40 years of his life. But if it is contributed by ARNI, then you are supposed to continue it for the rest of his life because you are not supposed to reduce the dose or take off the drug once the ejection fraction improves. Now we are in a dilemma. Now you can say the same dilemma with ACE inhibitor. No, I don't have the same dilemma with ACE inhibitor because it has been shown if you give ACE inhibitor for 1 to 2 to 3 years, you can stop it. You can still get the benefit. You are not. There is no recommendation to continue ACE inhibitor lifelong with that low ejection fraction, something like that. It is with ARNI mostly. So there is the question comes: should I give this patient a chance to come back in 6 weeks to 3 months time? If he is still in HEPREF, I shift from ACE inhibitor to ARNI. And if it improves, I continue with ACE inhibitor as per requirement of his blood pressure, his diabetes, and other things. Then my job is easy. Otherwise, and sometimes I also asked to McMurray that what is the harm in giving 10% benefit you are giving? It's not anyway inferior. It is superior, but may not be significantly superior. So why not on the day one? Because I am going to change to after 3 months anyway. So why this hassle again to change and stop for 36 hours and so on? They said, but there is a significant defaulter with hypotension. You know, cough and hypotension you cannot equate. Cough is, I mean, you can always tolerate, you can stop, you may continue, but hypotension is something serious. And once there is hypotension, the patient's compliance decreases very severely. And it's very difficult to give any RAS blockade after that. So why do you take the chance? As there is no clear superiority. So there are arguments on both sides, you know. So that's why even the SGLT2 inhibitor is not given in the acute MI setting for the same argument. If the ejection is low today and it is good with SGLT2, are you sure it is due to SGLT2 or patient's own recovery? If it is due to patient's own recovery, then you don't need SGLT2 after 3 months. If it is not, it is due to SGLT2, then you have to continue it for next 50 years. So I think we have got some area or scope for thinking for individual patient. If you think, no, this patient is going to have LVF for long term, no question, he's so badly done. So it is better to start ARNI from day one. But if you think, no, he's a reasonable patient, there's a high chance he will go back to normal ejection, normal life, NOIHA will go off, then better to continue with Ramipril for the time being and see how things go. So that is my thought. What do you think, sir, all of you?
No, as you told, I agree with those points. Number one, if a patient is in heart failure, you have started ARNI, and now he comes with a ejection fraction of 50%. I will not stop ARNI because he has tolerated the drug well. And if the patient was receiving, if he is not receiving ARNI from the beginning, he was on ACE inhibitor. After 6 weeks, he comes and ejection fraction is 50%. There is no reason why I should start ARNI. Unless you are thinking a situation where he has heart failure with a preserved ejection fraction. So if he does not have heart failure, whether preserved ejection fraction or no preserved, if he does not have heart failure, I am not going to give him ARNI.
Sharma, what's your current practice at the moment? What do? You see a lot of MI patients coming up and you give ACE inhibitor, but then do you give ARNI or ACE inhibitor? What do you do?
No, I give usually ACE inhibitor.
I'm asking Dr. Sharma.
Yes,
Dr. Sharma, what is your practice rather?
Sir, usually the patient with it is basically all depends on the patient profile. If patient is having patient is in heart failure with MI and other things, then we prefer then ARNI. Otherwise, we can go with the ACE inhibitor. So we have a both choice after MI.
How frequently you encountered symptomatic hypotension with ARNI, starting the ARNI with acute MI patients?
Usually, sir, patients, if it is not a late presentation or if a patient is come to the time in the golden time period for primary PCI, then usually patient if doesn't have a reduced ejection fraction or not in a cardiogenic shock or something like that, then only we usually doesn't start ARNI.
Yeah.
We only start ACE inhibitors.
Yeah,
so that is the criteria basically.
It's a safer option to start. Post titration is also, I agree. Now the last bit, sir, what do the guidelines suggest? Let's see. All of us know what the guidelines are there, but still just to go through you. Major clinical guideline of post-STEMI on 17 ESC and ACC also, that ACE inhibitor for STEMI with anterior location, as I was saying, ejection below 40, particularly with diabetic hypertension, etc., class 1A. ARB, if ejection below 40, and the same criteria, 1B, as Dr. Sharma was telling. So you can continue, but if not tolerated, that is a clause they always give. ARB in bracket, if ACE inhibitor not tolerated. So it is there, it is very acceptable, but why don't you give the preference to his big brother? If the big brother fails, then the little brother.
Only, obviously the criteria is the same, that if patient is not able to tolerate because of cough or because of other things,
like that,
then you have to change it.
Yeah. And ACE inhibitor for all STEMI within 24 hours is 2A. Because we know that it is effective, but there is no clear-cut data, so it is 2A, not 1. So these recommendations depend on the how many randomized trial you have got in your pocket and so on. So it is very scientific. And 2020 ASC guideline, they said ACE inhibitor or ARB in case of intolerance are recommended in patient with heart failure with reduced ejection below 40, with diabetes or CKD, unless contraindicated like severe CKD, hypertension, etc. And why do you need it? To reduce all-cause mortality. Very interesting. To reduce all-cause mortality, to reduce cardiovascular mortality, and to reduce cardiovascular morbidity. So all-cause mortality is also part of the game. that is class 1A, also beta blocker and MRA. So post-MI, state of the art. So central illustration here is very interesting, came in 2018, a bit old. So time-dependent therapies for post-MI infarction of heart failure. Index MI, 0 hour immediate perfusion for STEMI, early revascularization for cardiogenic shock, early initiation of ACE inhibitor within 24 hours. 40% of survival benefit from ACE inhibitor is conferred in first day. That is those big trials of 20,000, 50,000 patients when it started within day one. At 24 hours, avoid beta blocker for first 24 hours for ongoing heart failure. So beta blocker when the patient is dry, not when the patient is wet. Early introduction of aldosterone antagonist, benefit is time dependent, should be started within 7 days, preferably before discharge. Re-evaluate eligibility for beta blocker therapy every day during hospitalization and start it in the first opportunity you get. On discharge, it is critical to titrate dose of medication, including ACE inhibitor and beta blocker, to optimal level and post-discharge. I think this is a very nice and simple way of crystallizing our thought. So early ACE inhibitor offers maximum benefit, no beta blocker in a rush. So beta blocker with a little bit of thinking process and up-titrate them as much as possible. So Jack acknowledged IR as the first ramipril study in 93. And this review came in 2018, after almost 25 years, that ACE inhibitor should be administered within first 24 hours with ejection below 40 and below ejection 40, significant survival benefit from SAVE, IR and TRACE. We have already adequately explained. Now I come to my youngest colleague, Bappaditya. How early do you think an ARNI can be initiated in a patient post-MI? We have discussed, but now it's your free thought. The field is yours.
As we have already discussed, starting at ACE inhibitor as early as 24 hours after AMI offers the maximum benefit. And from the Paradise AMI, we have already seen that ARNI, although not statistically significant, but still the numbers are in favor of ARNI. So we can start ARNI as early as 24 hours after AMI. Also in the Pioneer HF trial, it has been shown that in acute decompensation heart failure also, we can start ARNI as early as 24 hours. So my take is, if you have to start a RAS inhibitor, start within 24 hours, and ARNI is preferable over AC inhibitor.
What dose of ARNI you usually start with, Bappaditya?
So, sir, SBP more than 100, I usually start in a low dose, 50 milligram twice daily. SBP still better, say 120, start 50, you would up-titrate within 1 week. And SBP below, between 90 to 100, I am little bit skeptical in starting ARNI.
Do you give it that half dose of 50?
Yes,
and
in sometimes
BD?
I give a half tablet twice daily.
25 BD to day 1 or day 2 and then see how things go. Do you check the postural hypotension in these patients? They are all CCU patient, always lying down with the monitor.
Mostly, sir, these are CCU patients, so I usually do not see the postural hypotension, but when they are shifted to ward, if there are any symptoms of giddiness, then only I test for postural hypotension. Very
interesting that before writing, mobilize the patient and allow toilet, you must see the postural hypotension at bedtime. Because many times after 3 days in bed, when patient goes to toilet, he collapses. Yes. So this is a very important, I think all of us should remember that tell the sister or the house staff to check the postural hypotension on the first time the patient stands after 3-4 days of in bed. So as you said, Paradise was starting point was from 12 hours onward up to 7 days. So we can start depending on the blood pressure. But hemodynamic stability is very important, Bappaditya.
Yes, sir.
If the patient is going on having arrhythmia, is having on inotrop, having infusion of a diuretic, then I won't venture with any of these medicines.
Yes.
Yeah, because we need to stabilize the patient without going into the hemodynamics. So, Dr. Behra, I come back to you to the end, 2-3 minutes. In the post-MI patient after revascularization, at what systolic pressure do you initiate ACE inhibitor therapy? Not ARNI, but ACE inhibitor.
This is a basically clinical question. The patient must have a stable blood pressure. More than 100 has to be there. And then if you are giving ACE inhibitor, don't forget about You have to call the patient or make the patient sit for a few hours or call them after 1 or 2 days, see his blood pressure. If his blood pressure has come down to 80, but the in our setup, basically, you do not start with a very high dose of ACE inhibitor, which is done in the Western countries. In fact, what you can see is that, in fact, they were also very cautious in a higher trial, which involved more than 3,000 patients. Their mean dose of, out of all patients, though they gave 10 milligram OD or 5 milligram BD, the mean dose was 6.4 milligram in the total subset of patients. So the dose was low. Dose was not that high. In certain patients whose blood pressure was good, then they have to increase the dose of Remi. So, systolic blood pressure is basically a clinician's prerogative. You have to assess the blood pressure and see exactly how is responding. Then you can give do the titration. And one thing I want to add here, we are discussing about ACE inhibitor in post-MI situation. In fact, there are quite a number of studies. One of the studies involved the Swedish study. They showed that the moment the patient is admitted to your ward, you are planning to give thrombolytic or primary PCI, best thing is you have to give antiplatelet with an ACE inhibitor. If you do that, your all the surrogate markers of inflammation and ischemia will be definitely less in patients who received ACE inhibitor. That trial, there are quite a number of trials to show that. So if you are planning to give ACE inhibitor, give early. The second
There's a
question.
little rider over here, Dr. Behra. Some people say before putting a dye, you withhold the RAS blockade to save the kidney, but it is controversial again. But you will remember also in our student days, while starting captopril, we had to admit the patient first to give the first dose of captopril for postural hypotension and so on. But with long-acting drugs like ramipril or perindopril, those things are nowadays are history. But still, I would rather start with an ramipril of 1.25 in these patients, then going up to 2.5, 5, and 10. But again, I remind myself that whatever be the total dose, it has to be divided into 2. So if I take 5 milligram ramipril, I better give 2.5 BD rather than 5 OD. That is how the studies have been done, and that might reduce the hypotension as well, the incidence of hypotension as well, if you keep one dose a bit lower. And how quickly you uptitrate, maybe every 2 weeks or 10 to 14 days to uptitrate, no, sir?
Yeah, you can, if the patient is hemodynamic status is stable, you can increase the dose. There is no reason you cannot do. But in our setup, actually, usually we have moribund patients. Average body weight is 40 kg, 45 kg. There you cannot, plan to increase the dose suddenly. Better you give low dose, call them 1 month back, and then you can increase the dose if necessary.
Usually 2 weeks, 2 to 4 weeks. We check the blood pressure, we check the creatinine, EGFR, we check the potassium, and then we go to the next dose level. These are the 3 things. In the post-MI patient revascularization, these are the rapid fire. Dr. Sharma, when do you like to start a beta blocker after MI? We have already hinted, but your comment, Dr. Sharma? When do you like to start a beta blocker after an MI?
When patient is wet, sir, then only we can start beta blocker as early as possible. That
when the patient is dry, and we can start as soon as possible.
Yeah.
Dr. Behra, again, which will be your preferred beta blocker?
I will be starting short-acting beta blocker first, with those which have shown mortality benefit, like metoprolol, bisoprolol, and all these drugs which are shown benefits, and they are short. Long-acting.
Carvedilol. Metoprolol, bisoprolol, carvedilol. These are the 3 drugs, and we can start with the lowest dose possible: 1.25 of bisoprolol, 3.125 BD of carvedilol. Metoprolol has to be long-acting. Again, we cannot give metoprolol tartrate. It has to be succinate, maybe 12.5 or 25 to start with. Bapaditya, at what dose you initiate and how do you uptitrate?
So you have already told.
Oh, sorry, sir. I didn't see that question. So
we can uptitrate every 2 weeks.
No. I have got something left over for you. MRA. Tell me how quickly or what is the starting dose of MRA and how quickly you raise it.
Sir, we can start at 25 milligram dose, and it is better to start within 1 week. MRA is better to start within 1 week to give the maximum benefit. 25 milligram starting dose, and I can uptitrate up to 50 milligram.
Spironolactone or eplerenone?
Eplerenone is preferred. Spironolactone can be given.
I think spironolactone has got more evidence, but eplerenone is safer, less side
It's
effect.
safer.
That is the only thing.
Yeah.
Dr. Gupta, will you advise an ACE inhibitor beta blocker combination?
No, actually, when patient is hospitalized, I usually start separate beta blocker and ACE inhibitor. And after discharge or at first follow-up, I usually start the combination tablet. In hospital, I usually keep separate beta blocker and separate ACE inhibitors.
Yeah. Now, I was a bit surprised by this slide, but now I'm smelling it is hinting at cardiac meto.
Yeah, right.
So that is why this last slide is. And another one for Dr. Gupta, post-reverse, if you find your LV systolic dysfunction still there, but without clinical heart failure, will you put the patient on RAS blockade?
Yeah, post this revascularization,
You
the
know,
patient
very
is
tricky
having
question.
low EF. I usually put patient on, if patient is already on ACE inhibitor, means patient came with prior ACE inhibitor, and I usually continue with that ACE inhibitor. If patient is coming with large infarct and there is LV dysfunction, I usually start them on ARNI.
So I think that here, if we see the guidelines very carefully, we sometimes say one or two lines that whether the patient has got symptom and or sign or history of symptom and or sign. So not necessarily on the day you are seeing the patient need to have symptom or sign. If the patient says that I was having out of breath climbing 2 stairs and I had a little bit of swelling at the end of the day for the last 6 months, it may not be present today, but that history qualifies him to be a patient of heart failure for our treatment purpose. So this is very important. Either symptom plus minus sign today, or there is a history of symptom plus minus sign before. And it is very difficult to assess the symptom when the patient is still hospitalized or bedbound, going to home, resting. When he goes back to normal life, then only he knows whether he is out of breath going back to his normal life. So we cannot say the patient has got no clinical failure. So clinical failure needs to be the patient to be fully explored to his usual circumstance, and then only we can say the patient has got no evidence of clinical heart failure. So I think for the time being, ejection below 40 should be our yardstick, and patient will develop symptom and sign in his own sweet time. We can wait for the patient to develop symptom and sign. So it's a retrospective way of going into it, even if he is not symptomatic today because he is bedbound. So that is, I'm taking it a bit light tone, but definitely I'll put them all on ACE inhibitor and ARB or ARNI. Do you consider NT-proBNP as a deciding marker for choosing ARNI over ramipril? Any taker? Do you think it's a deciding factor? Is it relevant?
No.
Absolutely.
NT-proBNP in our setup is not a relevant, investigation.
Yeah,
and
yeah.
we don't need help of NT-proBNP to diagnose a patient of MI, heart failure post-MI.
Yeah, yeah. So we don't guide our selection of medicine by NT-proBNP. It is more of to see the prognosis, how the patient is improving and so on, but we do not change our medicine on NT-proBNP. There is some interesting data. It was from from the paradigm heart failure that, of course, ARNI reduces NT-proBNP much more robustly than enalapril. But in a paradise heart failure, there was no clear-cut evidence that NT-proBNP relates with the event and whether NT-proBNP guided therapy is at all relevant. So we keep that subject at bay at the moment till we get some more data. So if, sirs, you allow me to wrap up, in post-MI patient with LVD, ACE inhibitor have consistently shown reduction in cardiovascular death and all-cause mortality. In this scenario, ACE inhibitors seem to have class effect. However, there is data to suggest that ramipril will be a preferred ACE inhibitor in the elderly people. Paradise MI, the first and only clinical trial for sac valve, did not outperform ramipril in acute MI. Of course, money is also a consideration going against. If there is no benefit, it's not cost effective. Ramipril 10 per day is the dose which offers the maximum benefit, but I would rather say 5 BD should be our motto rather than 10 OD. So that is one thing we can change our practice to. And I stop over here. If anybody wants to give a last word, you are welcome, or otherwise I'll give it back to Dr. Anup Hajare. Dr. Hajare, yeah.
What I want to say is that symptoms or no symptoms, the studies starting from Topcat to Georgian study, you remember, and then there's so many studies with the ARNI and then SGLT2 inhibitors. Ejection fraction 40% or less, it has to be given ARNI. Unless there is a contraindication to ARNI, you have to put them on ACE inhibitor or ARPs. So
As
ARNI
I said, the symptoms can wait. Symptoms can come later on. Don't worry about symptoms.
Right. ARNI is ARNI and ARNI is ARNI. So for last more than 7-8 years, ARNI is the drug of choice in this set of patients.
Failure. So for the moment, ramipril for MI and ARNI for chronic heart failure. I think that we agree and we end with a happy note. Dr. Hajar, please.
Thank you so much, sir. I think we had a very good discussion around this topic, sir. And thank you all for your valuable time and your guidance, sir. Especially Soumitra Ray, sir. You have been guiding for us for a long time and look forward for your guidance in the future as well, sir. Thank you, everyone. Have a good night.
Good night. Good night, Soumitra.
Hours of the weekend. Enjoy the rest few hours of the weekend.
Good night, Soumitra. Good night. Dr. Sarma, Dr. Kumar, Dr. Kumar, all good night.
Thank you, sir. Good night.
To all of you.